Hey guys, welcome back to my channel, The ENT Resident. Today we'll be discussing about perichondritis, which is one of the diseases involving the ear. You can also now purchase my notes. I have added links in the description. Okay, so perichondritis is this disease. More commonly, you'll see a lot of young females coming to you after they have made a ear piercing. They'll come to you with perichondritis. This can happen uh, when usually you end up going to get these ear piercings from a place which they do not know much about. They do not know the anatomy of the ear, and they can sometimes end up piercing the cartilage. And if it has not been done in aseptic conditions, it is one of the primary reasons why a lot of young females end up with perichondritis. Now, let's try to know what this disease is. So, perichondritis is when there is infection or inflammation occurring involving the perichondrium of the external ear, and this eventually leads to pus accumulation between the perichondrium and the cartilage. So, perichondritis is basically infection or inflammation of the perichondrium of the external ear. Now, let's try to understand what are the causes of this. So, now before we go into the causes, why is the conchal cartilage the most susceptible to perichondritis? That is because of three reasons. One is the skin over the conchal cartilage is very thin. Second is there is minimal subcutaneous tissue, so there's not much protection. And thirdly, because the pinna has a very vulnerable anatomical position, it is very open to any kind of external trauma. That is why these three reasons make the conchal cartilage particularly susceptible to trauma and subsequent infection. The two main causes over here is either it happens secondary to trauma, or third, a second cause is if there is some infection involving the skin or the subcutaneous tissue. So first, let's look into the trauma. How can trauma happen over here? If there is a laceration of the auricle, which can happen in road traffic accidents, if there is any surgery of the external ear, in case of frostbite, burns, chemical injury, if there is a hematoma of the pinna and then that undergoes secondary infection. This can also happen when you're trying to aspirate the hematoma, you may end up causing trauma to the cartilage. And lastly, is the most common cause that we know when you place a high piercing of the auricle for earrings, and when this piercing is in the area of the cartilage. Second reason is when there is superficial infection involving the skin, like in erysipelas, or the subcutaneous tissue, like in cellulitis, involving the external auditory canal or the pinna, and this eventually spreads to involve the perichondrium and the cartilage as well. So, this is the cause behind perichondritis. Now, what are some microorganisms involved over here? Very important MCQ question over here is the most common organism isolated in case of perichondritis is Pseudomonas aeruginosa. Other than this, we can also see Streptococcus, Staph aureus, gram-negative organisms like Proteus, Enterococcus, and Escherichia coli. But the most important one is Pseudomonas aeruginosa. This is a MCQ question that you may get. Now let's try to understand what is the pathogenesis behind this disease. So, whether there has been any secondary trauma, secondary to a trauma, or there is any infection, which is most commonly by Pseudomonas infection, this eventually leads to development of an abscess. Where does this abscess form? The abscess will form between the perichondrium and the cartilage. So if this is the cartilage, on top of it, we have a layer which is the perichondrium. So the abscess will form in between these two layers. And as it does, what it will do is it will lift off the perichondrium from the cartilage. So now, if this is the cartilage, this will be the perichondrium. So now this has been lifted off. So you can see some space has come between the perichondrium and cartilage. And this will end up disrupting the blood supply to the cartilage. So it will cut off this blood supply. Now, as the blood supply is cut off, our vascularity to the cartilage has reduced, and which will eventually lead to necrosis of the cartilage And if this is prolonged, it will lead to fibrosis, and eventually, extensive fibrosis will lead to a deformity of the pinna. And this again here is a very important MCQ question. Is we can see something which is known as cauliflower ear, also known as pugilistic ear or the boxer's ear. So this is a deformity which occurs as a complication of the process of perichondritis. So this is how we develop perichondritis. Now, certain individuals can be predisposed to developing this. So the risk factors involved here are diabetes and if any patient is immunosuppressed. These two cases, they will be more predisposed to developing perichondritis. So now we discussed about the etiopathogenesis. Now let's move on to what are the histological changes that will happen in perichondritis. Firstly, we'll see hyperplasia of the dermal layers. The subcutaneous tissue will thicken up. There will be an intense infiltration by polymorphonuclear leukocytes. The perichondrium will also eventually thicken up, and then there will be destruction of the cartilage by the phagocytes. These are the histological changes that we'll see in perichondritis. Next is what is a classification? How do we classify this? So there are two classifications. First was given by Prasad et al., where there are three stages. Stage 1 is when there is early perichondritis without any abscess. Stage 2 is when there is perichondritis with the presence of fluctuant abscess. And stage 3 is when there is perichondritis, fluctuant abscess, and cartilage destruction as well. So these are our three stages according to Prasad et al. But a more practical classification has been erysipelas of external ear, cellulitis of external ear, perichondritis, and chondritis. So these are our classifications of perichondritis. Now let's try to see what will our patient come to us with. What are the symptoms and the signs that we are looking for? So first of all, there will be a history of an underlying trauma to the external ear. So the patient may come to you with, okay, there has been a road traffic accident, or maybe a young female who has gone for ear piercing. So there'll be some kind of history of trauma to the external ear. And the patient will complain of there is this warm sensation over the pinna. The pinna is painful when you try to move it. Then there is also swelling of the pinna with forward displacement. So the pinna gets displaced forwards. And lastly, if it has stayed for a very long time in the later stages, there can be deformity of the pinna, which we discussed is known as the cauliflower ear or the boxer's ear. So we are seeing typical signs of inflammation over here: warmth, pain, swelling, even redness. And the pain that they are saying that it'll be a very dull kind of pain, which is slowly increasing in severity as the stage of the disease passes. Very important to know here, if you look at the image over here, this is how a typical perichondritis of a ear looks like. You can see this is very reddish and inflamed, and there is a swelling involving the pinna as well. But the lobule, you can see that the lobule looks absolutely normal. The lobule is normal because the lobule does not have any cartilage. Now, because this is a disease involving the cartilage and the perichondrium, the lobule of the ear gets spared. And the severity of the pain that the patient is complaining and the swelling of the pinna that you will be seeing, these are the indicators of true perichondritis. And that will help you in separating out and from the other differential diagnosis of erysipelas and cellulitis. So these are our symptoms. Now, as we can see in the image itself, when you inspect the ear, we can see that the pinna is looking very reddish and very puffy, like very swollen up. There'll be edema and the inflammation of the auricular skin. There is marked edema of the skin, and you can see that the normal contour of the pinna is lost. So, as it progresses, the normal contour also keeps getting lost. And as the disease progresses without any treatment, the skin starts to become thick and erythematous with areas of necrosis as well as discharge. And at the ultimately late stages, you will find discharging sinuses, and last of all, we'll find deformity of the pinna. So this is a disease, if you treat very early with the antibiotics, you will be able to stop the progress of the disease to become a deformed ear. And when you try to palpate this ear, you will see that the area is very tender. You may also see some discharge of pus if there is a fluctuant swelling. and a discharging sinus. So that's all that we'll see when a patient comes to you with perichondritis in its early or late stages. Coming to investigations, mostly this is a clinical diagnosis, but if the patient, say, has not been responding to antibiotics, you can take a swab from the discharging pus and send it for culture sensitivity. And before you start treatment in this patient with aminoglycosides, you should definitely perform a renal function test, because you should have a baseline number before you start aminoglycosides, because they have severe side effects on the renal function. So these are the two investigations that are relevant to perichondritis cases. Next is, what are some differential diagnoses of this case? One is relapsing polychondritis, which is a systemic condition where there is involvement of cartilage at multiple sites in the body. And these patients will also have concurrent vasculitis and other ocular conditions like scleritis or iritis or keratitis. And second differential diagnosis is non-Hodgkin's lymphoma of the pinna. So these are our two differential diagnoses of perichondritis. Now let's discuss how are we going to treat this case. So when a patient comes to you early, you can actually be managing them on an outpatient basis easily by giving them oral antibiotics, doing proper oral toileting and debridement if necessary, and keeping the patient under close observation. Very important, again, MCQ question over here is, the drug of choice for perichondritis is ciprofloxacin. Why is that? Because ciprofloxacin has excellent cartilaginous penetration. So this drug is able to penetrate the cartilage. And secondly, it also has high activity against Pseudomonas, which is the main causative organism in perichondritis. Therefore, ciprofloxacin is our drug of choice. Now, it goes without mentioning that in case of children, if you're giving fluoroquinolones, we should advise the patient to be monitored for toxicity, and we should be very careful about the dosage that we give in children. Now, say that you have given this all of this antibiotic and still the patient is not responding. If this infection is very severe and you are not seeing any clinical improvement in the first 24 to 36 hours of oral antibiotics, then we have to move on to give the patient parenteral antibiotic therapy by intravenous route. In these cases, what are some choices that we have? We can give ciprofloxacin, tazocin, ceftazidime, meropenem, according to these doses that are mentioned over here. So that's about our antibiotics. Next is, say if the patient has come to you with a subperichondrial abscess, which is fluctuant. In that case, just giving antibiotics is not going to cut it. You have to perform an incision of drainage, and you have to remove all the necrotic tissue and cartilage that you are seeing. They should all be debrided out, because if you do not remove them, the tissue is not going to be able to heal. So after you remove all the necrotic tissue, we should also place a drain under a pressure dressing so as to reduce any permanent deformity from happening. If there is a case of burns, in that case, iontophoresis, which is also known as electromotive drug administration, is given. Now, this is used as a means of effective local antibiotic delivery without the systemic absorption. And this will help in creating an electric field to drive the medication through the skin and deliver at a high tissue concentration. So, this is used in case of burns. Next is, if we see that we find a case of perichondritis which is resistant to any kind of antibiotics that we are using. If we are just using antibiotics and it's not responding at all, no matter what antibiotics we have changed to, in that case, sometimes we can give low dose radiation for about 3 to 4 sessions, where we use zero point 0.8 gray of radiation over a period of 2 days. That can help in resolution of the case. Lastly is our resistant cases. Now, see, if we have tried all of the treatment that I have mentioned above, we have done incision and drainage, we have removed all the necrotic tissue, we have given them parenteral antibiotics, yet after all of that, the patient is still complaining of persistent pain, suppuration, and is showing extensive signs of inflammation. In that case, we will term them as a resistant case. Now, what will we do in a resistant case? First of all, we'll aggressively excise off all of the necrosed cartilage, including the overlying skin and subcutaneous tissue. If the entire area is involved, then we'd perform a total chondrectomy by giving an incision in the helical margin. And we split the ear in a bivalve fashion. Necrotic cartilage is resected out, and we place in a very fine mesh gauze in between the flaps and change it daily. And we'll also have to ensure that continuous drainage and irrigation with an antibiotic and steroid solution is maintained so as to preserve the structure and the form of the auricle. We also place fenestrated polyethylene tubes in the subperiosteal tunnels on either side of the cartilage. Then this will help us in irrigating twice daily. So this is the treatment for the resistant cases of perichondritis. Next, let's talk about what are some preventative measures that we can take so that we do not end up arriving at this stage itself. First of all, for any children, for any young females, if they are going for earrings placement, it should be taken in mind that it should not be placed into the cartilaginous spina. We should avoid the cartilage area. And also, it should be done under aseptic conditions. Second is any surgery which involves in and around the ear, we should be very careful about avoiding trauma to the cartilage, and we should not place tight head bandages because that can also cause some pressure necrosis. Third is if there is a hematoma of the auricle, we should drain it very fast and immediately and maintain careful aseptic techniques. Lastly, management of burn injuries to the ear should include prophylactic antibiotics against the gram negative bacteria, and we should perform local daily dressings and remove all the eschars and the crust. These are some ways by which we can prevent the development of perichondritis. Lastly, we'll discuss about the complications of perichondritis. If perichondritis is not treated in time, as we discussed, it can lead to the development of a subperichondrial abscess, which will further lead to an avascular necrosis of the underlying cartilage and will lead to deformity of the pinna. The deformity is known as boxer's ear or cauliflower ear or pugilistic ear. Other than this, some other complications could be fatal septicemia secondary to streptococcal infection, subacute bacterial endocarditis, and necrotizing fasciitis of the neck. These are some of the complications of perichondritis. So that's all about perichondritis today. If you have any further questions on this, please note them down in a comment section and I'll get back to you. Thank you.